Metabolic disorders. Classification. What are metabolic diseases? Metabolic diseases are disorders that disrupt energy production, nutrient processing, carbohydrates, fats, proteins, cellular biochemical pathways. They can be broadly divided into inherited, genetic disorders, acquired, lifestyle-related disorders, nutritional deficiencies, excesses, endocrine, hormonal disorders, cellular energy dysfunctions. Inherited, genetic, metabolic disorders. These are typically rare, caused by enzyme deficiencies, and often present early in life. Key subgroups: carbohydrate metabolism disorders, diabetes mellitus type 1, glycogen storage diseases, galactosemia, amino acid disorders, phenylketonuria, maple syrup urine disease, homocystinuria, lipid metabolism disorders, Gaucher disease, Fabry disease, familial hypercholesterolemia. Other genetic categories: mitochondrial disorders, for example, Maine-LAS, urea cycle disorders, organic acidemias, lysosomal storage diseases. These disorders are individually rare but critical for understanding metabolic pathways. Acquired, common metabolic disorders. These represent the majority of disease burden in modern populations. Core cluster: insulin resistance spectrum, metabolic syndrome, type 2 diabetes. These conditions are driven by visceral fat, poor diet, physical inactivity, lipoprotein disorders, dyslipidemia, characterized by high LDL, high triglycerides, low HDL, purine metabolism disorders, gout, closely linked to insulin resistance and diet, obesity-related dysfunction, visceral obesity, adipose tissue inflammation, ectopic fat disorders, non-alcoholic fatty liver disease, often considered the liver manifestation of metabolic syndrome, nutritional metabolic disorder. These arise from deficiency or excess of nutrients. Deficiency disorders: iron deficiency, pellagra, excess states; overnutrition, vitamin toxicity, rare; endocrine metabolic disorders. Hormones regulate metabolism, so endocrine dysfunction leads to metabolic imbalance. Hypothyroidism, hyperthyroidism, Cushing syndrome. These affect metabolic rate, lipid levels, and energy balance. Cellular energy metabolism disorders. At the deepest level, metabolism depends on cellular energy systems, NAD+ pathway dysfunction, mitochondrial impairment. These are cross-cutting mechanisms seen in aging, diabetes, neurodegeneration. Cross-cutting mechanisms. Across all categories, several core biological processes unify metabolic diseases. Insulin resistance, chronic inflammation, oxidative stress, mitochondrial dysfunction. These mechanisms explain why many diseases overlap and coexist. Best practical coding systems for metabolic diseases: clinical, ICD-10 and SNOMED-CT; research, MESH; rare, genetic, OMIM; data, labs, LOINC; integration, UMLS Metathesaurus; ICD-10. Best for clinical diagnosis and billing, widely used in hospitals. Groups metabolic diseases under from E00 to E90, endocrine, nutritional, and metabolic diseases. Examples: E11, type 2 diabetes; E78, disorders of lipoprotein metabolism; E79, purine metabolism, gout. Although thousands of metabolic diseases exist, most of the global burden is driven by just a few: metabolic syndrome, type 2 diabetes, dyslipidemia, fatty liver disease. Classification with percent contribution, USA. This is a broad group of conditions that disrupt the body's normal chemical processes, metabolism, which convert food into energy and building blocks for growth, repair, and maintenance. These disorders can be inherited, genetic inborn errors of metabolism, or acquired, and they range from common conditions like diabetes to rare genetic diseases. Main types and examples. Category: approx percent of U.S. population. Metabolic syndrome, 35%. Diabetes, within carbohydrate disorders, 12%. Lipid disorders, genetic, 0.5%. Lysosomal disorders, 0.02%. Mitochondrial disorders, 0.02%. Amino acid disorders, 0.004%. Urea cycle disorders 0.003%, organic acidemias 0.002%. What is metabolic syndrome? Metabolic syndrome is a cluster of conditions that occur together, increasing the risk of heart disease, stroke, type 2 diabetes. It's not a single disease. It's a combination of risk factors driven mainly by insulin resistance and excess body fat, especially abdominal fat. Carbohydrate metabolism disorders. Diabetes mellitus, type 1 plus type 2, 11-12%. Galactosemia, 0.0003%. Glycogen storage diseases, 0.001%. Total category contribution, 12%. Metabolic syndrome, acquired cluster. Affects 33-38% of U.S. adults. Total, 35%. While there are thousands of distinct metabolic disorders, including over 1,400 rare inherited ones, these four acquired conditions represent over 95% of the total patient burden in clinical practice. Statistical breakdown of the Big Four. These conditions are essentially a single cluster of metabolic dysfunction driven by insulin resistance. Their prevalence is staggering compared to other categories. Condition. Estimated global prevalence. Approx. % of population. Dyslipidemia. 35-40%. One of the most common metabolic disruptions worldwide. Metabolic syndrome. 25-30%. Varies by region, highly correlated with obesity. Fatty liver disease. MASLD. 25-30%. Now the most common chronic liver condition. Type 2 diabetes. 10.5%, affecting over 500 million adults. Why they dominate the hierarchy? Acquired versus inherited. Inherited disorders, Gaucher, PKU, etc. While numerous in variety, they are individually rare, often affecting only 1 in 10,000 to 1 in 100,000 people. Acquired disorders, the Big Four. These are driven by environment and lifestyle. Because they share a single mechanism, insulin resistance, they often co-occur in the same patient. The common soil theory. In clinical ontology, these four are often viewed as different branches of the same tree. If a patient has one, there is a high statistical probability they have the others. 70% of type 2 diabetics also have fatty liver disease. 0.80% of people with metabolic syndrome also have dyslipidemia. Gout and thyroid disorders fall into different medical categories than the acquired metabolic cluster. While they involve metabolic processes, they are primarily classified under rheumatology gout and endocrinology thyroid. Here is how they fit into the broader statistical and clinical landscape. Gout, the metabolic arthritis. Gout is increasingly classified as a metabolic disorder because it is driven by hyperuricemia, excess uric acid, a metabolic byproduct. However, its primary clinical manifestation is inflammatory arthritis. Prevalence. It affects approximately 3-4% of the global adult population. The link. Gout is considered a sibling to the other disorders mentioned. About 75% of gout patients also have metabolic syndrome. It is often the painful alarm that alerts a patient to deeper metabolic issues like insulin resistance or dyslipidemia. Ranking. While widespread, it affects a much smaller percentage of the population than the Big Four, which are in the 25-40% range. Thyroid disorders, the metabolic regulators. Thyroid conditions, hypothyroidism, and hyperthyroidism are endocrine disorders. While the thyroid regulates metabolism, the underlying cause is usually autoimmune, like Hashimoto's, rather than a breakdown in how the body processes nutrients like diabetes. Prevalence. Thyroid disorders affect roughly 10-15% of the population globally. The overlap. Thyroid dysfunction can mimic or worsen metabolic disorders. For example, hypothyroidism can lead to weight gain and high cholesterol. Dyslipidemia. Hyperthyroidism can cause glucose intolerance, potentially complicating type 2 diabetes management. Classification. In a hospital setting, these are managed by an endocrinologist rather than a metabolic specialist, though endocrinology and metabolism is often a single combined department. Summary comparison. Condition, primary category, global prevalence, connection to acquired metabolism, gout, metabolic, rheumatology, 4% strongly linked to insulin resistance and diet. Thyroid, endocrine, 12% regulates metabolic rate, often coexists with T2D, the big four, purely metabolic, 10 plus. The primary drivers of metabolic health costs. The 5 main components. You are diagnosed with metabolic syndrome if you have 3 or more of these. 1. Abdominal obesity. Large waist size, visceral fat around organs. 0.2. High blood pressure equals 130/85 mmHg or on medication. 0.3. High blood sugar. Fasting glucose equal 100 mg DL. 0.4. High triglycerides equal 150 mg DL. 0.5. Low HDL, good cholesterol. 40 mg DL men, 50 mg DL women. What causes it? Genetic. Most inherited metabolic disorders result from mutations in single genes that code for enzymes, cofactors. Acquired. Diabetes, metabolic syndrome, liver kidney failure, certain medications, toxins, or nutritional deficiencies. Mitochondrial DNA mutations, inherited only from the mother. Core problem, insulin resistance. Your body cells don't respond properly to insulin. Glucose builds up in blood. Main contributing factors: poor diet, high sugar, processed foods, type, physical inactivity, excess body fat, especially belly fat, genetics, poor sleep, per stress. Why it's dangerous. Metabolic syndrome significantly increases risk of heart disease 2 times risk, stroke, type 2 diabetes 5 times risk, fatty liver disease NAFLD. Symptoms: usually no obvious symptoms early on. Possible signs: large waistline, fatigue, darkened skin patches, insulin resistance sign. Many people don't know they have it until tested. How common is it? Affects about 33–38% of US adults, more common with increasing age, obesity, sedentary lifestyle. Roughly 1 in 3 adults has it. Metabolic syndrome diagnosed if present 3 or more of these: obesity, large waist size, high blood pressure, low high-density lipoprotein cholesterol, known as good cholesterol, high triglycerides, glucose intolerance, high fasting glucose. What is visceral fat? Visceral fat is fat stored deep inside the abdomen, wrapped around vital organs like liver, pancreas, intestines. It's different from subcutaneous fat, the fat you can pinch under your skin. Why visceral fat is dangerous? Unlike regular fat, visceral fat is metabolically active and acts like an endocrine organ. It releases inflammatory chemicals, hormones that disrupt insulin, fatty acids into the bloodstream. Health risks: insulin resistance, type 2 diabetes, heart disease, sancoid cholesterol and triglycerides, high blood pressure, fatty liver disease. It's a key driver of metabolic syndrome. Diagnosis: newborn screening. Many countries screen for PKU, galactosemia, MCAD deficiency, etc. Blood tests: amino acids, organic acids, acylcarnitines, lactate, ammonia, urine organic acids. Genetic testing: targeted gene panels, whole exome sequencing, enzyme assays, biopsy, liver muscle. How to reduce visceral fat. Diet: most important. Reduce sugar and processed carbs. Increase protein, fiber, whole foods. Exercise: cardio, walking, running, strength training. Even 30–45 minutes a day makes a big difference. Lifestyle: sleep, 7 to 9 hours. Stress control, lowers cortisol. And medications if needed. GLP-1 drugs, semaglutide, tirzepatide, metformin in insulin resistance. Key insight: you don't need to be obese to have high visceral fat. Some people look normal but have skinny fat, TOFI. Others may have visible fat but lower internal risk. Simple summary: visceral equals hidden fat around organs, strongly linked to metabolic syndrome, measured indirectly via waist size, highly dangerous but reversible. Treatment and prevention. Lifestyle changes, most important. Lose 5 to 10% body weight, eat whole foods, vegetables, protein. Reduce sugar and refined carbs. Exercise, 150 minutes week walking, gym, sports. Medications if needed. Blood pressure drugs, cholesterol lowering drugs, statins, diabetes medications. Drugs for metabolic syndrome. Point 1. High blood sugar, insulin resistance. First line and most common, metformin improves insulin sensitivity. Other options, GLP-1 receptor agonists, semaglutide, liraglutide, SGLT2 inhibitors, empagliflozin, dapagliflozin, thiazolidiniadones. Hyoglitazone. These also often help with weight loss and heart protection. Point 2. High blood pressure, hypertension. Common drug classes: ACE inhibitors, lisinopril, enalapril, arbors, losartan, valsartan, calcium channel blockers, amlodipine, thiazide diuretics, hydrochlorothiazide. Point 3. High triglycerides, low HDL, dyslipidemia. Primary drugs: statins, most important. Atorvastatin, rosuvastatin for triglycerides, fibrates, fenofibrate, gemfibrozil. Omega-3 fatty acids, prescription. Niacin, less used today. Point 4. Obesity, weight management. Modern highly effective drugs: GLP-1 agonists, semaglutide, Wegovy, Ozempic, tirzepatide, Zepbound, Mounjaro. Other options: orlistat, phentermine, topiramate, bupropion, naltrexone. Point 5. Blood clot, cardiovascular risk reduction, aspirin low dose in selected patients, antiplatelets if high risk, weight loss medications. Point 1. Prescription weight loss medications. These are used for obesity BMI greater 7 with comorbidities like diabetes or hypertension. A. Xenical, Ollie, orlistat. Mechanism: lipase inhibitor, reduces fat absorption in the intestine. Side effects: oily stools, flatulence, diarrhea. Counseling point: take with meals, supplement fat-soluble vitamins A, D, E, K. Category: non-stimulant, long-term weight management. B. Adipex P, Lomera, phentermine. Mechanism: sympathomimetic, appetite suppressant, stimulates CNS. Side effects: insomnia, increased heart rate, elevated BP, nervousness. Counseling points: short-term use, less 12 weeks, monitor BP, avoid in cardiac patients. Category: stimulant. C. Quicemia, phentermine, topiramate ER. Mechanism: phentermine, appetite suppressant, topiramate enhances satiety. Side effects: paresthesia, insomnia, constipation, dry. Counseling points: pregnancy, monitor heart rate. Category: combination therapy. D. Contrave naltrexone, bupropion ER. Mechanism: appetite control via CNS, reduces cravings. Side effects: nausea, constipation, headache, increased BP. Counseling points: monitor mood, seizure history, contraindication. Category: combination therapy. GLP-1 receptor agonists. Typical weight loss results from clinical trials and real-world data often over 1-1.5 years. Typical: Wegovy, semaglutide, around 15% average body weight loss, injectable. A new oral Wegovy pill became FDA approved and launched in early 2026. Zepbound, tirzepatide, a dual GLP-1 GIP agonist. up to 16–22% in some studies, often considered one of the most effective currently available. Injectable. Saxenda, liraglutide, around 5%, 8%. Injectable. Or forglipron oral pill from Eli Lilly, potentially available in 2026 mechanism. Increases satiety, slows gastric emptying, dosage, subcutaneous injection, titerated weekly, side effects, nausea, vomiting, constipation, rare pancreatitis, counseling points, rotate injection sites, monitor for GI symptoms. Point 2. Over-the-counter, OTC, weight loss options. Orlistat 60 mg alley. OTC, lower dose. Caffeine-containing products, mild stimulant, not clinically proven long-term. Green tea extract, Garcinia cambogia, limited evidence. Weight management is the foundation, core treatment. Lose 5–10% of body weight. Reduces insulin resistance. Blood pressure, triglycerides, visceral fat. This alone can sometimes reverse the syndrome. But treating metabolic syndrome is really about fixing several interconnected systems at once: glucose, lipids, blood pressure, inflammation. Nutrition, most powerful lever. Focus on high fiber, vegetables, whole grains, lean protein, healthy fats, olive oil, nuts, reduce sugar, refined carbs, ultra-processed foods. Diet directly improves glucose and lipoproteins. Next groups of medications used are lipoprotein management drugs. Targets: decrease low-density lipoprotein, LDL, bad cholesterol, and decrease triglycerides. Increase high-density lipoprotein, HDL, good cholesterol. How? Diet, less sugar. Medications if needed. Statins, fibrates, omega-3, lipid-lowering drug classes. Statins, e.g. atorvastatin, simvastatin, rosuvastatin, are HMG-CoA reductase inhibitors. They block cholesterol synthesis in the liver, which upregulates LDL receptors and clears more LDL from the blood. They are first line for most patients with high LDL and proven cardiovascular benefit. Cholesterol absorption inhibitors. The primary example is ezetimibe, brand name Zesha. It works by blocking the absorption of dietary and biliary cholesterol in the small intestine via inhibition of the NPC1L1 transporter at the intestinal brush border. This reduces the amount of cholesterol delivered to the liver, leading to lower circulating LDL cholesterol. It's often combined with statins for additive LDL lowering effects. Fibrates, e.g. fenofibrate, gemfibrozil, activate PPAR alpha receptors, which regulate genes involved in lipid metabolism. They primarily lower triglycerides by enhancing fatty acid oxidation and lipoprotein lipase activity. Omega-3 fatty acids, prescription strength. High-dose omega-3, for example EPA and DHA from fish oil, such as Vascepa or Lavazza, reduce hepatic triglyceride synthesis and increase clearance. Prescription forms are used for severe hypertriglyceridemia. They can complement statins and have additional anti-inflammatory benefits. In this book, you can read about other classes of drugs relevant to the specialization of a pharmacy technician. Several metabolic agents and nutritional supplements. Carnitine. It is the brand name for levocarnitine, a naturally occurring compound essential for turning fat into energy by transporting fatty acids into mitochondria for fuel, primarily used to treat low carnitine levels and certain metabolic disorders. Treats carnitine deficiency. For people whose bodies don't make enough carnitine, often due to genetic defects or kidney disease, hemodialysis. Galactosemia treatment. Strict lifelong lactose-free, galactose-restricted diet. Eliminate milk, dairy, and all sources of lactose, including hidden sources like whey, casein hydrolysates, some fruits, vegetables with free galactose. Soy-based, elemental, or galactose-free formulas for infants. No curative drug exists. No specific enzyme replacement or small molecule therapy is approved or widely used as of 2026. Supportive medications. Calcium and vitamin D supplements, e.g. Oscal, Caltrate, Citrocal, calcium citrate. Viactive chews to prevent osteopenia, osteoporosis, very common due to dairy avoidance. Multivitamins, especially those without galactose fillers. NAD+, nicotinamide adenine dinucleotide, is a crucial coenzyme in every living cell, required for energy production, DNA repair, and metabolic functions, operating as an electron carrier in some reactions. Decreased levels have been observed linked to disorders including Alzheimer's and diabetes. The primary supplements that effectively boost levels of NAD+ are its precursor compounds, nicotinamide mononucleotide (NMN) and nicotinamide riboside (NR). Forms of vitamin B3, niacin, nicotinic acid, and nicotinamide niacinamide are basic precursors that can raise NAD+ at higher doses, but they are less efficient and specific than NR or NMN for targeted boosting. How these work together. Example typical patient. Metformin, glucose. Statin, cholesterol, ACE inhibitor, blood pressure, GLP-1 drug, weight, and glucose. So patients often take 2-4 medications simultaneously. Drugs for metabolic disorders that frequently appear on the PTCE Top 200 medication lists cover the categories diabetes, hyperthyroidism, hyperlipidemia, and gout. They are described in the relevant sections of this book. In this book, you can read about other classes of drugs relevant to the specialization of a pharmacy technician.